We are here with the RSNA webinar devoted to cardiovascular manifestations in COVID-19. My name is Diana Litmanovich and I'm the webinar lead. I'm an associate professor at Harvard Medical School, where I'm also serving as the chief of cardiothoracic imaging at Beth Israel Deaconess Medical Center. COVID-19 refers to the clinical manifestation of infection with severe acute respiratory syndrome coronavirus 2. And here comes the name SARS-CoV-2. As of July 27th of 2020, COVID-19 has affected more than 13 million of people and killed close to 600,000 people worldwide. As the knowledge from the clinical, translational, and basic science grows, there is also an increasing awareness of the cardiovascular manifestations of COVID-19 disease and its adverse impact on prognosis. There is also growing understanding of the pathophysiology of cardiac and diffuse vascular involvement, including neurocardiac, coronary, pulmonary, abdominal, and extremity vascular involvement. In other words, multi-system, multi-vessel involvement. The multi-system nature of the disease in significant number of cases with adverse impact on prognosis has been demonstrated and recorded worldwide. And cardiovascular considerations also impact the invasive and non-invasive treatments. The next part of our webinar will be devoted to the neurovascular disease manifestations in COVID-19 and will be presented by Dr. Akash Kansangra. I would like to thank RSNA for inviting me to lead the webinar, and I would like to thank all the participants that have found the time and devoted to creating those presentations, enlightening us on such an important and timely topic as the multivascular involvement in COVID-19 disease. Thank you very much. Who is an assistant professor of radiology, neurological surgery and neurology, and director of endovascular surgical neuroradiology and co-director of Stroke and Cerebrovascular Center at Washington University and Barnes-Jewish Hospital in St. Louis.
Hello, everybody. My name is Akash Kansangra, and I am an interventional neuroradiologist at the Washington University School of Medicine and Barnes-Jewish Hospital in St. Louis, Missouri. Today, I plan to talk to you about neurovascular disease and COVID-19, with a focus on stroke imaging and stroke treatment. Here are my disclosures, none of which are particularly relevant to this talk. You've probably already heard that there is a link between COVID-19 and stroke. Some of this discussion has been about direct links wherein suspected prothrombotic features of COVID-19 may actually produce stroke or stroke-like symptoms. This is, of course, really important. But also important are the indirect links, wherein the presence of COVID-19 in the community can alter the way that stroke care is delivered. In this talk, I will focus mainly on these final operational aspects. Specifically, I will discuss how COVID-19 has changed recommendations for stroke imaging and stroke treatment, and we'll also discuss actual observations about how stroke imaging and stroke treatment have changed during the era of COVID-19. We'll start with imaging, which is a key element of pre-treatment workup in stroke. So the first question is, what are the guidelines for COVID-19 screening prior to stroke imaging? Who needs to be evaluated for the possibility of COVID-19 before they can even get stroke imaging? The RSNA states that pre-imaging screening for COVID-19 is not needed for emergent imaging. This is a very accommodative message, and the RSNA deserves a lot of credit for not insisting on barriers to imaging for the very vulnerable population of stroke patients. Other societies, such as the Society for Neurointerventional Surgery, the SNIS, and the Society of Vascular and Interventional Neurology, the SVIN, both suggest some level of clinical screening in stroke patients prior to doing anything, which largely reflects the intensity and proximity of stroke teams to patients in early triage. Here is the complete guidance issued by or the complete guidance on pre-imaging COVID-19 screening that's been issued by the RSNA COVID-19 task force. Only a small part of this overall workflow is relevant for emergent stroke imaging, and specifically, if we have a patient who has suspected COVID-19 and has an emergent need for imaging diagnosis, such as stroke, that's right at the top of that flow chart. Then they go down to portable imaging, possible, generally not for stroke imaging, in which case they go straight to the imaging, and the only change is that imaging staff should take appropriate precautions in terms of droplet precautions, contact precautions, things of that nature. Note that PCR testing with the swab is not a part of this pathway. And so in essence, the RSNA recommendation is that acute stroke imaging can and should be performed without any added steps except for maintaining appropriate PPE during patient interactions. Now, what about changes in stroke imaging protocols themselves? So this is not the pre-imaging screening guidelines, but the actual method of imaging. The American Heart Association, the AHA, and the SNIS both recommend sticking to established pre-COVID-19 imaging protocols. The SVIN, however, suggests that it may be possible and reasonable to drop some imaging from this protocol if it reduces the possibility of exposure. Now, this mainly comes into play for patients in extended time windows. Strictly speaking, CT perfusion is a key element of patient selection for mechanical thrombectomy beyond 6 hours. And in this context, the SVIN argues that you might be able to get away with eliminating this extra imaging and replacing it with non-contrast CT if it helps to avoid an extra trip to the CT scanner that would otherwise not need to occur. Now, what about supplementary chest imaging? And specifically, should chest CT be part of an acute stroke imaging protocol? The RSNA COVID-19 task force actually suggests that chest CT can be used in the situation of unexpected surges or when quick throughput is required. That latter consideration, quick throughput, certainly applies to stroke because there's really not the opportunity to wait several hours for a PCR result to come back. Now, this recommendation from the RSNA is nuanced and seems to recognize correctly that chest CT is not really an optimal diagnostic test, but that in certain circumstances it may be better than nothing. The SVIN here suggests that chest CT may actually have a role for screening in patients who have quote-unquote positive pulmonary symptoms. I must say that this recommendation has been a little bit controversial and met with some uncertainty as a patient with positive pulmonary symptoms and a negative chest CT would still generally be regarded as a suspected COVID patient, so it's unclear what value a negative chest CT would have in this patient. It does not rule out the presence of COVID, but nevertheless, this is their recommendation. And then other radiology groups, such as a group of neuroradiologists and chest radiologists, I believe, that recently published an overview of stroke imaging in the American Journal of Neuroradiology, have resisted issuing formal recommendations one way or the other, but simply have noted that chest CT imaging has been applied in certain highly endemic areas as part of stroke evaluation. Now that we've discussed changes in imaging guidelines, we can talk about changes that we've actually observed in how imaging is being performed in the era of COVID-19. Probably the biggest change is the actual quantity of stroke imaging studies that are being performed. Our group recently published a paper that describes the volume of stroke imaging performed in the US using Rapid, which is one brand of perfusion imaging software that's available in the US and actually elsewhere in the world. Now, using data from over 230,000 patients in the US, we identified a 39.1% decrease in the volume of scans that are being performed during the worst part of the during the pandemic. You can see here on the graph these dots correspond to actual stroke imaging volumes, and that drop is precipitous and unmistakable. Now, because we had such a large patient group with about 231,000 patients, that same data set allowed us to do a fair amount of subgroup analysis and further work out the observations. And among the more interesting findings was that decreased imaging utilization of stroke was seen across the entire spectrum of ischemia volume. Now, ischemia volume is a strong correlate of stroke severity. So these data suggest that the magnitude of decrease was seen across the entire spectrum of stroke severity. And so it's not just patients with minor stroke symptoms who are staying home and not seeking care. It's everybody, mild strokes and severe strokes, are seeking care or receiving care at reduced rates. We also looked at stroke imaging utilization data on a state-by-state level. On this chart, states are arranged by the number of scans being performed in each state on average, meaning that the error bars are smallest on the left-hand side of the image and get progressively larger towards the right-hand side of the image. So the data is more robust on the left side of the chart. The key takeaway from this chart is that there were dramatic and fairly consistent decreases in stroke imaging across virtually every state. This data indicates that it was not just endemic areas that saw reductions in stroke imaging, but all regions. And it's really quite remarkable just how closely so many different states with very different situations with respect to COVID, all these states saw decreases that were broadly consistent with that national 39.1% decrease in imaging. So with that, we've reviewed changes in guidelines and observed and observations with respect to imaging in the era of COVID-19. But what about stroke treatment itself? In terms of patient selection and say, specifically who should get thrombectomy, the American Heart Association and the SNIS both recommend that selection criteria for treatment remain unchanged, mainly because IVTPA and mechanical thrombectomy are such powerful and effective therapies to reverse the effects of stroke. Now, of note, there is one major but hidden caveat to this recommendation, which is that current guidelines only advocate for treatment, for stroke treatment, and specifically mechanical thrombectomy, in patients with MRS scores of 0 or 1. That designation, that MRS score of 0 or 1, essentially denotes patients who do not have any substantial disability prior to the onset of stroke symptoms. The idea here is that patients with significant pre-existing disability will not be able to benefit from invasive procedures as they can have a poor prognosis to begin with and will be unable to participate in rehabilitation and all those other things that really make stroke treatment very effective. What does that mean for critically ill COVID-19 patients, say those are on ventilators? They certainly have a severe pre-existing condition. There are no written guidelines here, but anecdotally I can tell you that colleagues in endemic areas are generally not performing mechanical thrombectomy or other invasive interventions in these patients, specifically those who are on ventilators. The mortality rate of patients with COVID-19 on ventilators is thought to be extremely high, perhaps between 80 and 90%. And that's mainly in patients who don't even have a stroke. So not performing mechanical thrombectomy in patients with extremely poor prognosis is really a matter of balancing what's almost certainly a futile procedure against the very real risk of exposure for the team. Now, what about the procedure itself? Should there be changes to how we conduct ourselves during a case? The Society for Neuroscience and Anesthesia and Critical Care, SNAC, is the strongest, has issued the strongest recommendations amongst all stroke-related societies. And what they've suggested is that teams should use full PPE in all stroke patients with unknown COVID-19 status, which really is actually most stroke patients because many of these patients cannot affirmatively deny exposures or symptoms because of their stroke. As for intubation, SNAC and SNIS both recommend a very low threshold for intubation, mainly owing to the fact that unplanned conversion from an unintubated patient to intubation creates a major aerosolization hazard for not only the anesthesiology team, but also the neurointerventional teams that are in the room with the patient. Curiously, the SVIN actually recommends the opposite, but speaking with colleagues, I think most people are erring on the side of intubation when necessary. Here's our own approach at the Myocardial Institute of Radiology at Washington University. So any patient who has confirmed COVID-19 or who has some concern, so they're either a person under active investigation for COVID-19, they have suspicious history, suspicious symptoms, or they have chest imaging with suspicious findings, or lastly, if they're just impaired by the stroke and unable to affirmatively deny history or symptoms, then they're treated as a presumptive positive, and they're treated with full COVID-19 precautions, meaning that our teams don full PPE and that the patients are intubated in a negative pressure room. Now, patients who are low concern for COVID-19, those who have no history, no symptoms, and the negative chest CT, we just use conventional precautions and intubate those patients as we would have pre-pandemic. It's important to note that we don't actually do EVT, or excuse me, mechanical thrombectomy any differently in these two groups. It's really just a matter of intubating and gowning up a little bit differently based on the risk factors. Now, what treatment trends are we observing? Across the world, stroke and neurointerventional teams are reporting sizable decreases in stroke admissions, rates of intravenous thrombolysis, and mechanical thrombectomy. It's pretty remarkable that there was a similar magnitude of decrease in stroke admissions across the world. If you look at China, Spain, and the US, these numbers are broadly consistent, somewhere between a mid-20s to mid-30% decrease in the number of stroke admissions that we're seeing during the pandemic. There was also a pronounced decrease in the amount of IV TPA administered and the amount of mechanical thrombectomy being performed. Again, those numbers vary a little bit from country to country, but they're broadly consistent. It's important to note that these studies have identified different trends and do not agree on whether there were greater delays in presentation or not. These studies are just inconsistent. In fact, these results about potential patient delays for presentation may depend heavily on local context, whether not only where the patient is in terms of country, but also local systems of care, whether they're being evaluated first at one hospital before being transferred versus presenting immediately to a qualified stroke center. Here's a visual representation of some of these same trends, this time from a hospital system in Northeast Ohio. The gray shaded box is denotes the pandemic period. And what these data show is that the number of stroke alerts shown in solid black and the number of telestroke calls shown in the dashed black fell pretty noticeably during the pandemic period. And that further below in gray, the number of patients who received IV thrombolysis shown in solid gray, and the number of patients who received mechanical thrombectomy shown in dashed gray was also much lower than in the pre-pandemic period. Now, what about the cases themselves? Are they any different? When we're doing a mechanical thrombectomy, are there any differences in how those cases go? The Neurointerventional Radiology group at Columbia University in New York would say yes. They recently published a very instructive series of 5 consecutive mechanical thrombectomy cases in patients who are COVID positive. And what they found was several interesting features. First, the box at left, you can highlights what they found was a very higher NIH stroke scale. That's a measure of stroke severity. Those of us who treat stroke regularly, we've seen numbers like this, but we also often treat patients with NIH stroke scales in the range of 10 to 20. And this group found remarkably higher NIH stroke scales on average than we would see in otherwise typical stroke patients. So that's interesting. In terms of laboratory abnormalities, they found pretty sensitive abnormalities that all point to the strong possibility of coagulation abnormalities. They found elevations in D-dimer, ESR, CRP, INR, PTT, and IL-6 across really all of these patients. Looking at the third box, they also found a very large number of large proximal occlusions involving the ICA, the internal carotid artery. Now, those of us who spend our lives treating stroke, anyone in interventional radiology will recognize that this distribution of clot location is aberrant. Most of the stroke we treat using interventional techniques are M1 occlusions involving the proximal middle cerebral artery. ICA occlusions represent an important but small minority of overall cases, somewhere between 10 to 20% of all cases. And in this series, the group identified 80% of patients as having an ICA occlusion as opposed to something more distal. This group has also suggested that these presumed COVID-19 related clots were particularly prone to fragmentation during thrombectomy. Here's one image from their publication, and what you see here is an imaging panel with panel A showing basilar thrombus, and panel B and C showing thrombus in the cervical ICA. So this patient actually has clot in multiple major intracranial arteries, so that in itself is atypical. But after thrombectomy, what you see in panels D, E, and F at the bottom is that what was once a mid-basilar occlusion has fragmented and migrated to the distal P1, as you see in panel D. And even after that clot was worked on in figure F, or panel F, excuse me, you can see that later there's been development of additional clot fragment in the right P1. So this is a little unusual. We don't typically see this much clot fragmentation during cases, so there may be something to this. Does this information change how mechanical thrombectomy is actually performed? Not necessarily, but my takeaway from this data as a neurointerventionalist is that we should be prepared to treat clot fragments and generally expect that these cases will not necessarily be quick or easy. And with that, I'll wrap up. Here are the references that were used in the talk. And I am always happy to answer any questions from my colleagues at RSNA. And I wish everyone well, and thank you for your time. I wish you all safety as we face the ongoing threat of COVID-19 in our communities. Thank you.
I would like to thank RSNA for inviting me to lead the webinar, and I would like to thank all the participants that have found the time and devoted to creating those presentations, enlightening us on such an important and timely topic as the multivascular involvement in COVID-19 disease. Thank you very much.